Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this education episode, we are talking about athletic groin pain.
A great topic for our first CEU of the year.
Oh man, you're right. You know the best part is we've had a lot of interviews, which has given me a chance to prepare a lot for this episode.
How many articles are we sitting at?
I gotta be over 20.
Nice.
I have to. There's no way. I've done a lot of reading. A lot of reading time.
If you guys want to check out the citations, stick to the end. We'll talk about them. But for now, what are the objectives that we're going to be talking about?
Yes, we are going to be talking about Sandra's favorite thing, the relevant anatomy implicated in athletic groin pain. It's important, don't worry. We'll also identify modifiable risk factors associated with athletic groin pain, implement current terminology to differentiate between different causes of groin pain, and then discuss interventions for the management and prevention of, you guessed it, athletic groin pain.
All right, let's get the anatomy over with.
Wow, again, it's just sounding so bummed about anatomy.
Anatomy's great, but on a podcast.
Yeah, it's a little rough sometimes.
All right.
So, of course, with groin pain, we're talking about your hip adductors, your adductors. And there's a lot of muscles in that area. It's a pretty big group, right? You have your gracilis, your pectineus, and then you have your adductors themselves, adductor brevis, adductor magnus. And one that we would really like to highlight on this episode is the adductor longus. Most people like to talk about adductor magnus because it has some relation to hamstring pain. But in this episode, we're all about longus here. So the reason this is so important is because it's been shown that this is the most common structure injured in groin pain. So why is just this one muscle possibly the big culprit in athletic groin pain? Well, if you look at it, it has proximal attachments that sit right at the junction between the lower extremity and the trunk, and that junction is the pubic symphysis. Just imagine it kind of being like that SI joint, but in the anterior side of the body.
Actually, that's a really good analogy.
I know, right? That was pretty good, huh? I'm proud of myself. Don't worry, guys. Patting myself on the back right now. And so is Sandra. So the reason this is important and the reason why it has a pretty good analogy to the SI joint on the posterior side is because literature has shown that there are fascial attachments between the adductor longus and the pyramidalis muscle. Now, if you never heard of that muscle, it's a small little muscle that sits just inferior to the rectus abdominis. So it's like your lower abs, essentially.
What does it do?
You know, that's the best part. It's not really big enough to exert force. So it's kind of debated on what exact role it does.
Posture?
I would view it more of a stability thing as another muscle to increase intra-abdominal pressure. So more of a stability muscle.
Okay.
There's also connections to the contralateral external oblique, and this one I thought was very interesting. There are fascial connections from one adductor longus to the contralateral adductor longus.
That is fascinating.
So there's a lot of tissue and fascia and just everything crossing this pubic symphysis and going into the core musculature.
So I'm just jumping ahead, but I'm thinking if we have fascial connections, that means we could probably treat one side and affect the other?
Exactly. It's almost like everything's connected. So now this brings up the question, because most people, when they think of groin pain, they like to think of the rectus abdominis. So where does the rectus abdominis come into play with groin pain and adductor longus? It's a little debatable on how important rectus abdominis is. There's some evidence that shows the sheath that covers the rectus abdominis connects with the adductor longus. But the interesting thing is some studies also say like, oh no, that doesn't connect there. It connects to the pyramidalis. I think we're kind of splitting hairs there just because I don't know if anyone else remembers their cat dissection from anatomy class, but trying to dissect the abs, like your rectus abdominis, external obliques, internal obliques, transversus abdominis, all those, is darn near impossible for me.
I don't remember.
Oh,
I mean,
God.
probably.
Well, let me tell you, it's terrible. So I think that's really kind of splitting hair. It depends how maybe you dissect them.
Splitting hair or splitting fascia?
Exactly. So that's kind of debatable, but so far from what I've seen is the literature is consistent, showing a connection between the rectus abdominis and the gracilis. So
What do you mean by that? Like connection?
So there's the tendon that comes off of the rectus abdominis will actually blend with some of the fascia to the gracilis itself.
Okay, but I gotta say, when I'm hearing this and I'm thinking about the rectus abdominis, like that has such a major role on pelvic movement that I feel like even though it's not fascially connected, you still have to take into consideration that it has a role on pelvic movement, which has a role in your adductors and optimal length.
Yes, absolutely. And what we're trying to get at too is when you think of the adductor group, there's a lot of muscles in a very tight area. And where they all connect is even a tighter of an area. It's very small. So, yes, if you do MRI studies and if you go in on surgeries, more than likely the adductor longus is the culprit for groin pain. But that doesn't mean it's like that for everybody. So, if you're having groin pain, what if it's coming from the gracilis? And we've shown that rectus abdominis has a really direct tie to the gracilis. So either way, it would behoove you, there's my SAT word for the day, to treat the core musculature as they are very related to the adductors. Maybe not individual muscle to muscle, but I think as a group you can safely say there's a strong connection between these two segments.
Okay, I gotta admit that anatomy was kind of fun. And I can't wait to use the pyramidalis muscle as a fun fact, like a party trick.
Really, that's what we were going for with including that, is this is fun trivia.
Yeah, that's what I meant.
Exactly. It could be a party trick too. If you could individually activate your pyramidalis, I think you should win a lot of bets.
Okay, let's talk about risk factors.
So, I know we've talked about risk factors for other conditions, and usually strength is always mixed. First of all, everyone studies it, and then for like certain musculoskeletal conditions, it's always like, maybe. For groin pain, adductor strength has a lot of support that says if you have weak adductors, you are at a significant higher risk of developing groin pain. And this has been identified in multiple ways of testing. So like your adductor squeeze test. So we've all kind of done this, right? Knees bent and they squeeze their knees together or knees straight, which is interesting how they do it in these studies is to get an objective number. They put like a blood pressure cuff in between their knees or their ankles, depending if it's knees bent or knees straight, and then just have them push against it. And then it kind of goes to like if they have pain, like, oh, okay, that's it. Or whatever their max would be if they're pain-free.
Okay, wait, that's totally something you can do in the clinic.
I know, right? Isn't that kind of cool?
Do you have like parameters? Like
I believe they pump it to the baseline pump is 20 millimeters of mercury.
Okay, that's something we all have.
Exactly. Useful info.
Wow. That's pretty cool.
And then they've also done like your regular MVIC testing, so just like isometrics and even isokinetic strength, like eccentric strength being different has also been shown to be a risk factor for groin pain.
I have to stop you really quick because I just have to look back. I feel like it's pretty obvious that weakness in adductors is kind of a risk factor.
Exactly.
Like weakness comes with pain.
And I think a reason, absolutely it does. And I think one of the reasons why you get a better idea of adductor strength being a risk factor than opposed to other conditions that have looked at strength for, their respective muscle groups is because when you really look at the function of the adductor group, because there's so many different muscles that sit there, they literally do everything. They don't just yes, obviously they create hip adduction, but they also help with the gait cycle. So as your legs in extension, they help initiate that initial flexion. Then, hip flexors take over and all that stuff. They're also huge in providing stability for the lower extremity and the pelvis. So they literally do everything.
Well, it kind of makes sense because usually weakness comes with tightness. So
exactly.
If you're tight and weak and you do any sudden movement where your leg goes into abduction, then boom,
and also because of how vital they are to stability and movement, means they're probably going to fatigue a lot faster. So if you have a much lower threshold to decrease in strength, there's another reason why, boom, like you said, like certain movement, boom, gone. We don't want adductors gone. It's not good.
No, you just said they were vital.
They're very vital. You see, I would say like most people don't realize how important their like adductor group is until it gets hurt.
Oh, yeah.
And then it feels like it hurts with everything you do because they do everything.
Okay, let's talk about range of motion.
Yeah, so range of motion, again, has been looked at as a possible risk factor for athletic groin pain. And as kind of expected with other musculoskeletal conditions, is literature is very mixed. Some studies say can identify that it is a risk factor. If there's limited internal rotation, sometimes limited external rotation has been shown. And then also on the reverse side, some studies have found no evidence supporting that range of motion is a risk factor. So my argument would be that range of motion in isolation of itself is not a true risk factor. But possibly if you were to combine it with other factors, like maybe a high training load, fatigue, maybe like what we talked about, muscle weakness, maybe then range of motion may have a better emphasis on being a risk factor and showing those who may be at risk of groin pain.
I feel like combinations of risk factors are generally what we're looking at anyway.
Exactly. And from a clinical standpoint, that's what we're doing. We're trying to find basically dysfunction. We're trying to find, well, what's dysfunctional and what's not. Whereas in research, a lot of times it's really hard to control for everything. So sometimes examining this one thing is easier for the study, but it may not be showing the true meaning of what this measure can tell us. And the reason I think range of motion has more bearing on as a risk factor when it's combined with other things is because it's already been shown that limited internal rotation has been shown to increase the movement of the pubic symphysis, which means if that pubic symphysis, which doesn't move very much, moves too much, you're going to see higher shear forces and demand across the joint, which we've already shown, especially with adductor longus, there's a lot of connections that are happening there from the lower extremity and the trunk itself that helps transmit that force from the lower extremity up and then vice versa from the trunk down. So if you're getting any inefficiencies there, it's going to create a lot of stress, and that's how you can probably see a breakdown right there.
So I think mostly what I'm taking from this is that I can use range of motion in my rehabilitation and prevention of re-injury, individualized to the patient.
Yes, and then understanding like, okay, I know this person has limited range of motion. Well, if I'm starting to notice that their training load's really high, or hey, they're starting to complain of more soreness than other people, then like, hey, this could be a problem. Like we may need to address this and adjust this person's workload. So that's range of motion. Another topic, which seems kind of obvious, especially because it's the biggest risk factor for almost all musculoskeletal injuries, is previous injury. So those with previous groin injury have shown a decrease in groin strength and also lower patient-reported outcomes. So the patients themselves perceive less function after they injured their groin.
Well, isn't decreased adductor strength a risk factor anyway?
Exactly. It's both.
It's so after you recover from injury and you still don't have that strength, then you're literally at risk because of a previous groin injury and because you have decreased strength.
Exactly. And it's highlighting the fact that we may need to start changing the way we approach our rehabilitation of groin injury, which we will talk about towards the end of this episode. But what I thought was really interesting, as I said, previous injury is a risk factor. And they actually found that if you had a previous injury of other joints like the ankle or the knee, even the shoulder, they showed that you were at a higher risk of developing groin pain.
Why? Because of slings?
Exactly. It could be because of the slings, because of previous injury, right? Any injury to the extremity could affect how the core functions. You could argue that the adductors serve a core function in stabilization. So again, this highlights the importance of anytime we do rehab, we need to focus on the entire body and the motor system itself. Because as we've talked about before, pain and injury changes how the motor system functions. So we need to be able to retrain that motor system in order to create those efficient movement patterns and hopefully reduce the risk of additional musculoskeletal injury, even if you're treating just one type of injury.
Body's too smart for its own good.
Yes, it is very good at adjusting, but doesn't realize how that adjustment can be detrimental sometimes.
Okay, so I have someone who's coming to me with groin pain. How should I approach that? What's the evaluation?
So this has been the tough thing, especially in the research is, okay, well, what do you define groin pain? There's a lot of structures can cause groin pain. So researchers out there have basically tried to set a set parameter of how to define groin pain to make it easier to study and also make it a little bit easier for us clinicians to be able to evaluate it. So they actually came up with a classification system. So one step of the system are actual clinical entities of groin pain. So this is kind of like everything around those adductors that could be causing the groin pain. So one entity is adductor-related groin pain, which if you look at a lot of studies that use this classification system, this is going to be your more common one. And to classify someone into this group is basically tenderness of the adductors and pain when you perform adduction resistance tests. So like a bent knee, like the ball squeezes, straight leg squeeze, anything like that, that's going to create pain. They could probably be thrown into that category. The next entity is iliopsoas related pain. And this can be identified with pain with resisted hip flexion and or pain with hip flexion stretching. The next one is inguinal related. So this is pain and tenderness in the inguinal canal region. They may have pain with abdominal resistance or valsalva, but it's also important to note that there is no hernia present in this kind of condition. See, a lot of times people with hernias, they would classify as groin pain. That's why they needed to create a better definition. So this is taking out people with hernias because that's its own condition. And then the last one for the clinical entities of groin pain is pubic-related groin pain. And that's essentially tenderness of the pubic symphysis or the adjacent bone itself.
So groin is basically an umbrella to all these.
Exactly. But as we know, not just these areas can cause pain in your groin. So they also created a hip-related groin pain, and that's essentially any pathology related to the hip joint. So it could be FAI, it can be labral tears, anything that's actually coming from the hip joint that's creating that referred pain to the groin would be categorized as hip-related. And then finally, they left it open to your other causes. So there are some patients with SI joint dysfunction and pain that's leading to groin pain. Lumbar disc, if you have a disc herniation, it can cause referred pain to the groin. So that's how they kind of left it out. So essentially, what's going on is they're not telling you how to evaluate someone's groin. They're giving you set parameters that when you perform your evaluation, it can help guide you and start promoting your thinking on categorizing these areas as you go through a full eval to help rule out other conditions.
Got it. So like if I'm looking at hip-related groin pain, then I might want to rule out like labrum tear and like FAI.
Exactly.
Okay.
It's also important that these different groups and all these umbrella terms, they're not independent of each other. You can have adductor-related groin pain and hip-related groin pain all at the same time. That's why it's very important to do your full evaluation, rule out these other conditions, because just because, hey, they have pain, they have tenderness with palpation to the adductors and then resistance testing creates pain, like, oh, well, I'm done. That's it. It's adductor-related groin pain. Well, no, they can also have inguinal-related groin pain too, or they can also have FAI associated with that as well. So keep that in mind. This is more just a way to help organize your evaluation and help you remember to rule out all these other conditions and hopefully streamline your evaluation a little bit.
Or like when you're trying to apply an ACE wrap to someone's hip, and you're like, which way does it hurt to move your leg?
Yes, which way am I going again? Is it?
And they're like, oh, it hurts when I like squeeze my legs together and also when I lift. And you're like, okay.
Got it.
Okay, so let's move to the management.
Yes, now that we know what's happening, we got to do something about it.
Yes, please.
And as with any condition, of course, we want to focus on an intersegmental approach to our rehab. And there's a lot of good evidence supporting this approach. So essentially what that means is focusing on all connecting segments to that hip joint and the groin itself. So you definitely want to strengthen the core in addition to your adductors. Yes, we obviously want to strengthen your hip adductors, as we talked about. That is important to preventing re-injury, but we don't want to do that in isolation. Never has rehab been successful when it's just focusing on the injured area and just that. And plus, we've already talked about how the core has such a vital role in supporting the adductors and help supporting the force that is being transmitted through the pubic symphysis. So the core is going to be very important in this process. I would also say it would be very beneficial to strengthen the glutes.
Absolutely.
Of course, because the glutes do play a key role in providing stability across the pelvis itself as well. I would caution to be careful with the ratio of strength between the adductors and abductors. There's some evidence that says that can be a cause of injury, but a lot of that is already because of the present weakness in the adductor. So I would say as you're doing your rehab, you probably focus on strengthening the adductors first and then transition to adding the glutes as well, just to make sure that ratio doesn't continue to get bigger. But a lot of times with that ratio, it's because the adductors are already at a weakened level, and that's what's throwing that off.
So it's more like maintenance of glutes and in increased strength in adductors.
Exactly, basically.
I'm actually really surprised that we've gone through this whole thing, and this is the first time glutes have come up.
I know, glutes are awesome, and we just saved it for the end, I guess.
That's a great sound clip right there. Glutes are awesome.
And as we said with the whole intersegmental approach, is strength only plays a small role. And they actually found in a study attacking like an intersegmental approach to groin pain that strength itself only accounted for 11% in the improvement in patient-reported outcomes.
I need a second to process that.
Is that not crazy? So when they did like the statistical analysis, because you can say like how much of the change is associated with what variable you're measuring, and about 11% they're saying came from just strengthening alone. So I think how you have to look at this is it emphasizes the importance of addressing other areas of dysfunction, like if range of motion is dysfunctional, that can be an area of improvement. And also a big one, again, motor control. Strengthening does not necessarily mean you're affecting someone's motor function. You're just making the muscle stronger. You're letting the muscle be able to produce higher amounts of force. But we also want to learn how to control our muscles. We want to be able to learn appropriate movement patterns. And so I think that's why you only see like, oh, well, strength only does 11%. Why am I doing it? No, it plays a role. We just need to attack all these other areas in our rehabilitation.
I think functionally, now that I'm thinking of it, I feel like it's hard for people to add adductors functionally because of the valgus collapse that we don't want to see.
Exactly. And that's why I think a lot of it is they do play a role in stability of the knee. And that's why there's a big interplay between the adductors and the hip abductors as well. So when you're doing movement rehabilitation with someone and making their movements more controlled, you still obviously want them to not have a huge valgus collapse. Or if they go into valgus, they need to be able to get out of it quickly. Also, looking at how the pelvis is being controlled. The adductors do play a role in stability of the pelvis. So I still encourage that you work on those control issues. You work on that movement efficiency. So with our rehabilitation, we need to be able to define when someone's ready to return to play. And as we've seen in various injuries, return to play should be utilizing some kind of criteria. As clinicians, we do a good job of it. We just don't do a great job of documenting, I'd say, or having a system to it. A lot of times it's very quick, just asking them certain things. But it has shown that if you have a criteria on how you return someone to play, you'll see lower re-injury rates in athletic groin pain. And this was the study that looked at this was they used simple criteria. They literally just used the athlete's pain level, and if they progress through like 3 stages of the rehab. Like at each stage, if they were able to progress through that, they use that as their criteria. And they saw a pretty good decrease in the rate of re-injury. So just using a simple criteria like that already protected some athletes. So I would say we should be able to expand on that and use more functional tools like single leg hop, single leg, triple leg hop. Triple leg hop, that doesn't make sense. Single leg triple hop. Like doing stuff like that, I think will also give us a better indication of who's ready to return to play. Yeah, someone may have their pain gone and they progress through their rehab, but then when they start doing these more explosive activities like, hey, I'm going to jump 3 times single-legged, or yeah, that's right. Or I'm going to jump single-legged as far as I can. Oh, yeah, that hurts. Or my muscle function on my injured leg is not the same as my good leg. Well, there's an imbalance right there. They may not be ready to return to play. So I think if we expand our criteria to including those measures, we might be able to protect more athletes as they return to play.
Are we going to hit back on the fascial connection that you were talking about earlier?
Like, what do you mean?
Like between the 2 adductors and how they connect?
Well, yeah, that can play a role too. So now, if you see an imbalance between both legs, you might be seeing that the other adductor now has to take on that larger role, especially because of that connection between the two. So now it's even in a less optimal environment to do its own job. Now it's taking care of someone else's job, and you can see an injury there. You know, it's interesting. I don't think I saw a study that actually looked at that, like injury to the other adductor. That'd be interesting. It would make sense that could happen.
Yeah, that's when I usually check hips. I do a lot of balance work with my groin athletes.
Absolutely.
You can do a lot of single leg work, which is balance, and if you add resistance with a band, then you can do adductor or abductor, or you can play around with it and do both. You could do perturbations with the band, like if it's around their knee and they're doing single leg work, because that's good stability.
Oh yeah, definitely.
Also a lot of core. I really, because of my Pilates background, I really like to train the core as like a stable core with the upper extremities and lower extremities moving. And I think that that's so important when we're talking about adductors. I think one of my favorite things to do is speed skaters once they're ready, because that could really transfer to, okay, now, it's a big movement, but something smaller like breaking down or cutting on the field.
Well, also,
you can also do speed skaters changing directions.
And that's a big mechanism for getting an adductor strain, is cutting, a lot of side-to-side movements, kicking. So training them to be able to move optimally in that position is exactly what we're trying to do.
And it makes them gain confidence.
Absolutely.
I had a football player who just was so nervous about, that's exactly what he did to get injured.
Yes.
And so the more we did it in a controlled environment, then it was, okay, now I understand. I can trust my body a little bit more.
And again, it goes back to having criteria to return them to play. And one of that is, how do they feel? Because if they're going in feeling scared, they're not going to be able to protect themselves or move correctly, and it can actually create injury.
Yep.
So now that we know how we can kind of manage these conditions, how we should be returning them to play, it's always nice to prevent these things from happening to begin with. So as we have already talked about, hip adductor weakness being a big problem, the research that has shown that adductor strengthening in prevention has shown success. It is very valuable in decreasing the risk of injury. But I would say that it's not going to obviously prevent all adductor type injuries. So I think you need to start adding other wrinkles to your prevention. And I think one area to do that is training load monitoring. And it makes sense because, one, other studies have shown that for other injuries, but also over the course of a season, adductor strength has been shown to decrease. And this decrease in adduction strength has been shown to identify future groin injury no sooner than 2 weeks prior to the injury. So like if today all of a sudden I'm showing weakness, I am at a higher risk of getting injured 2 weeks from now.
I feel like that's like dehydration. You have to hydrate the day before that you want to be hydrated. You know what I
Exactly.
mean?
So it kind of highlights someone who's in the danger area. Hey, this person's at significant risk. We now need to adjust what we're doing for this person to make sure that they do not get hurt. And that's where training load monitoring can come in very handy, monitoring who's going to start feeling fatigued. I mean, obviously, it would be nice, like, yes, if you can test strength at certain intervals with your athletes, like, yes, that's very valuable. But like a lot of ATs out there, we just don't have the time and or resources to be able to do that. So another way of helping us monitor training load is just exactly that, monitoring that training load, being able to identify who's fatigued, how long have they been practicing, what's the workload at. You know, that might be a little bit easier to manage than, well, now we got to individually strength test everybody, look at the numbers. So
Yeah, going into screening, you could screen for anything.
you could screen for anything, and I think being able to just look at the load itself can help solve a lot more issues than just like, well, I'm going to test adduction strength, because that's just one injury that you're working on, right? Adduction strength's not going to tell you, you know, well, who might be at risk of spraining their ankle, right? Like that's not going to tell you those things, whereas training load monitoring can give you a nice big net to catch other risk factors. And that's all we got.
Cool. I think we covered a lot on the groin.
Yes, I told you, man, I was ready for this one. I had a lot of time to prepare. Spent a lot of time reading about groin.
Are you tired of it yet?
No, it was actually really interesting. I know you've become very confident with treating groin pain.
Well, I see them all the time.
And, it makes sense because a lot of that population, like the population of groin pain, tend to be sports that involve cutting, a lot of stop, starting, decelerations, and that's football.
Mm-hmm.
So in track, like, yes, we have it, but it's not the most prominent. So I see it every now and then. But now that I'm working soccer, that's become a little more common for me.
Yeah, I bet.
Yeah, so it has been really nice to be able to sit down and actually read this literature and just kind of change up how I do things as well. Because before I dove in, like, I didn't know about defining the different entities during the evaluation and how that can really help guide your treatment. If you're having hip flexor related groin pain, it may be ideal to address that hip flexor, as opposed to if during your evaluation the hip flexor doesn't seem to be the problem, then maybe you don't need to address that.
So what does our bonus content look like for this episode?
So for the bonus content, we're just going to kind of show that evaluation part, at least for identifying the clinical entities of groin pain. So like adductor related, inguinal related, and all those. And then we'll also just kind of go over some exercises that you can use that can help strengthen that adductor.
Looking forward to that.
Let's do it.
So this CEU episode is currently free, and it will stay free. Thank you to Precision AT until we continue to produce more CEU content. The way that we work here on AT Corner is we have 5 free CEU episodes, and the rest are password protected. So if you want access to those, head over to the show notes. We have all the links to our CEUs free and that you can purchase. Currently, the free also includes bonus content. So if you are listening to this when it is one of our latest 5 episodes, you can go ahead and actually go watch our bonus content that Randy just talked about for free. And that bonus content also gets you an extra 0.25 CEUs, so you don't want to miss out on that.
No, and we've had our latest 5 that have been up have been free for a while, it feels like.
They have been free for a while, so make sure you take advantage of this while you can.
Yes.
If you are listening to this past that point, don't worry. That means that we have 5 new free episodes. So head over to any of your favorite podcast directories or on YouTube to find the rest of our episodes. If you guys are new, we actually do every other episode as education or stories. This one was an education. Next week, we are going back to our stories. If you would like to submit a story of your experience working as an AT on different topics, head over to our Instagram because we post upcoming topics that you guys can submit. We also have a Facebook group if you guys want to join and network with other clinicians. That's down in the show notes or facebook.com/group/AT Corner podcast. If you're looking for more CEUs, this is the last fine print, I promise. We have a partnership with MedBridge, and They are offering $175 off of your year-long subscription if you use the code ATcorner. And again, all this information is in the show notes.
Yes, it's all great content, and also it might be best to get ahead of those CEUs before the reporting period. You have plenty of time, so might as well get ahead.
Absolutely. All right, Randy, you got anything else to add?
Thank you for helping us showcase athletic training behind the tape. Bye.